Good afternoon and welcome to the InterScience Conference on Antimicrobial Agents and Chemotherapy here in Chicago, Illinois. My name is Jim Sliwa and I am the Media Relations Manager for the American Society for Microbiology. ICAAC is the annual infectious diseases meeting of the American Society for Microbiology, and one tradition we have every year is an overview briefing for the media to give a basic overview of what we think are some of the more interesting research studies being presented at the meeting. We have here members of the program committee who will give their a basic synopsis of what they think are some of the most interesting research. First, we have Lindsay Grayson, who is the chair of the program committee, and he is with Austin Hospital in Austin Health in Melbourne, Australia. Next to him is Craig Rubens, who is the executive director of the Global Alliance to Prevent Prematurity and Stillbirth at Seattle Children's in Seattle, Washington. And finally, we have Laurent Kaiser, who is the head of the Laboratory of Virology at the University Hospital of Geneva in Geneva, Switzerland. Dr. Grayson, if you'd like to start us off.
Thanks very much, Jim. Well, just by way of overview, I guess for many of you, you will have seen the program, but there's a lot of things that have been happening this past 12 months in terms of infectious disease, whether it's E. coli outbreaks in Germany and throughout Europe, or whether it's emerging zoonotic viral infections such as Hendra virus, which has been particularly the case in Australia, or in particular, as for those of you who are at the keynote address, this emerging really serious problem with emerging gram-negative resistance. And this program reflects a lot of those issues, as well as continuing problems with other major pathogens that we're seeing throughout the world, such as Clostridium difficile, and of course problems with staphylococci and resistance, and greater knowledge about why they're causing infections and the severity of those. So there are many sessions, of course. It's the usual ICAAC, but there are many more things to do and see than you've got time to do. But what we thought we'd do today is break it into three parts. On my left, my colleague Laurent Kaiser is going to discuss the virology and transplantation issues in the meeting and the key features of the meeting that you might want to hear about. Craig Rubens is going to discuss pathogenesis, pediatrics, vaccines, and travel medicine and parasitology. And then I'll cover the other areas, clinical infectious disease and resistance. And you've already heard from Karen Bush this morning about new drugs. So we might start with Laurent, if you'd like to tell us about some of the key sessions that are coming up over the next few days about virology and transplantation and hepatitis.
Okay, so good afternoon, everyone. I have organized my talk, my short talk and brief overview in 4 different topics. First, respiratory viruses, then DNA and herpes viruses, hepatitis C and HIV at the end. So for respiratory viruses, we have this afternoon slide session, and I think that it's quite interesting slide session because we have quite a new description of new antiviral that are directed against mainly influenza. You know that neuraminidase inhibitors have been largely used during the last H1N1 pandemic, but the impact of this drug in hospitalized patients has not been assessed in placebo-controlled trials yet, and I am afraid that this will not be the case in the short future. This afternoon we'll get a comparison of an IV neuraminidase inhibitors called Peramivir against oseltamivir. This is session V403. The session will also provide results of study using new antiviral called favipiravir that inhibits the viral polymerase, so another target than the neuraminidase inhibitors, and another one that described the potential effect of sialidase inhibitors, again a third target against influenza. So we will have soon, hopefully, other drugs than the neuraminidase inhibitors to target influenza. This open the possibility also of combined therapy for severe cases. Concerning herpes and DNA viruses, You know that one general problem at the level of DNA viruses is that we mainly have drugs that target HSV, herpes viruses, and CMV for transplant patients. But we don't have many drugs that can target EBV, which is a cause of severe complications and lymphoma in transplant patients, adenovirus, and BK virus, 3 other DNA viruses. Generally, when you have an infection with these viruses, the only solution is to decrease the immunosuppression. You don't have antiviral. One drug which is in advanced clinical testing called CMX-001 will be presented this afternoon, but this is not a randomized trial. This is the result of a compassionate use program that have used this drug for salvage therapy in severe cases with adenovirus, BK, and other CMV infection. And this is really important for the transplant community. The presentation will be V499B. Of note, this compassionate program, for financial reasons, has been closed recently, and this is also an issue, almost an ethical issue that we have to keep in mind. There is other drugs that will be presented against herpes viruses as poster, but I will not go in details today. Then hepatitis C. We face a new era, a new challenge concerning hepatitis C. This is related to the recently approved protease inhibitors, boceprevir and telaprevir. These drugs have already changed our guidelines and therapeutic strategy. But despite these new drugs, we still need interferon-based therapy and ribavirin. So we still need the old-fashioned drugs, interferons and ribavirin, which limits also the possibility to treat patients. Another problem with these two drugs are they are limited to genotype 1, which is the most prevalent in our countries, but which is not so prevalent in some part of Africa or Asia. And this is really a problem. So during this session concerning hepatitis C, we will have a lot of sessions discussing how to manage hepatitis C in different populations, including HIV patients that are co-infected with HIV and HCV. Basically, you have to give 6 different antiviral drugs to these people. We will have presentations concerning a new protease inhibitors in advanced phase 3 called TMC435. It's presentation H3815A. And then we will have presentations of a review in a symposium that will discuss also the use of what we call small molecules that are other targets than the protease that are in the pipeline for hepatitis C. And this is very important if we want to achieve a treatment without interferon in these patients. The final question concerning hepatitis C is whether we will need to treat all cases or only cases with liver disease or advanced liver disease. And this is a debate that is basically between gastroenterologists and infectious disease specialists. Basically, the viewpoint of infectious disease specialists, or at least of most of them, is that you can eradicate the disease with a good treatment, so we don't need to wait complications before to initiate the treatment. But this is a really important question in the community. Let's move to HIV. We know that we have plenty of antiretroviral therapies that have proven to suppress HIV and prevent complications. What we have to learn today is that we have a new terminology that is called HIV comorbidities. And we have many sessions that are discussing what we call HIV comorbidities. This is not anymore AIDS events or infectious disease complications. There are complications related to long-term HIV, long-term infection, long-term inflammations, and long-term exposure to antiretroviral therapy, complications, cardiovascular complications, osteoporosis, etc. And this is really the important question at this time is how to manage this complication. So we'll have several interesting sessions on this, expert sessions also. There is also several abstracts discussing new treatments, new non-NNRTI inhibitors. One is called rilpivirine. New papers discussing different aspects of how to manage resistance or how to screen for resistance using ultra-deep sequencing or next-generation sequencing. And also, you will see that there is a recent trend toward the decrease of resistance transmissions for some of the old drugs like protease inhibitors. So you already see the impact of these drugs on the ecology of the virus. So I will not detail all the study that discuss new treatments, but you have several oral sessions discussing this. The last point concerning HIV is whether you need to treat everyone immediately, because the last question that is also a public health question is that you can show by several studies, this has been shown, and you have a slide session on this during this meeting that show that if you treat patients, you decrease rapidly transmission also. So you have a benefit at the individual level with comorbidities that are related to the treatment, but on the other side, you have the benefit for the community. So it's difficult to balance the two, and this is a hot question at this moment. And finally, concerning retrovirus, there is one session that will discuss the retrovirus called XMRV that has been linked to chronic fatigue syndromes during the last few years. That was driven a lot of investigations, and recent investigation published in Science showed that possibly that was contaminations. We will have an overview on these topics during one sessions concerning controversy in virology. I will stop here.
Thanks very much, Laurent. Right?
Sure. So there are some very interesting papers that have to deal with what we call pathogenesis of microbial disease and immune responses, and I'm going to summarize those now. We have two award-winning posters that came up that are really at the forefront or frontier of investigating how carrying certain genes or having a certain genetic background may predispose you to worse or different types of infections that occur with the same bacteria or microbe. The first is one that will be presented in poster session 008, paper B067, on the adreno-beta receptor 2 polymorphism that's associated with increased susceptibility to bacterial meningitis. And this is one of the first papers that's really looked at genetic background and susceptibility, and kind of goes along with what David Goldstein was reporting this morning on during his keynote address on really beginning to understand how different populations and different subgroups of populations are actually at risk for different types of infectious diseases. Something similar is a paper that will be presented this afternoon, poster session 007, paper B060, on clonal complex genotyping of Staph aureus that is associated with the likelihood of getting infective endocarditis in humans, but it has attenuated virulence in sepsis models. So this is actually looking at the bacteria and the different types of clonal types of Staphylococcus, one that may predispose to causing more in the range of infective endocarditis versus causing actual overt sepsis and bacteremia. So these should be very interesting papers. They won awards based on the program committee's review, and highly recommended that you take a look at those. There is a session on fungal bacterial interactions in clinical medicine this afternoon from 4 to 6 p.m. in W187A. This is a session that really is starting to look at the heart of how the ecologic changes between microbes can actually influence disease, and in some populations be either predispose those populations to disease or actually can be friendlies, if you will. There's one on Pseudomonas and Candida titled Friends or Foes by Deborah Hogan, that should be a really interesting paper. It's really looking at how ecological changes as these two pathogens colonize could actually either be friendly or opportunistic and cause disease. Tomorrow at 8:30, there is a session on new perspectives on immunodeficiency. And something that hasn't been highlighted at ICAAC a lot is the fact that over the last 10, 15 years there have been almost 200 new primary immunodeficiencies that have been identified that are unrelated to infectious diseases or other causes. The genes for those have actually been identified through modern genomic techniques. Each of these individual new primary immunodeficiencies come along with being at risk for being susceptible to different types of bacterial infections. And Dr. Steve Holland from the NIH is actually going to discuss new perspectives on immunodeficiency and how those bacterial infections are actually still emerging despite all that we're doing to try and protect those patient populations. Tomorrow also is a session on hot topics in vaccines. As we highlighted this morning in the keynotes, this is a really ripe area for lots of new discovery and certainly is as important as discovering new drugs. So that's tomorrow morning in room W187A and is a panelist discussion, so it'll be different than just hearing some people present. Also tomorrow morning is an update on new antiparasitic drugs for globally important infections. I don't know how many of you may be already aware that there is now a huge effort in what are called the neglected infectious diseases or in the developing world to identify new drugs that can be used for parasitic infections that cause millions of infections, oftentimes with other microbes at the same time. So that is going to be an interesting discussion, and one paper in particular talks about updating the use of intravenous artesunate for the treatment of severe and complicated malaria in the United States. And so the use of artesunate is not new, but how we are starting to use that in different populations and its important contribution to treatment of severe malaria is very important. It is in that session number 465. Also tomorrow at 11:15 is a session on new trends in vaccines where those discussing that topic will actually get into some of the newer approaches, not only to vaccinology, but combining different vaccines. There's one that's very interesting that I think is worth highlighting, G1-536, entitled A Bivalent Vaccine to Protect Against Streptococcus pneumonia and Salmonella. These are very disparate types of organisms, and to make up a vaccine that can do both would be quite interesting. Sunday afternoon in room W181C is a session looking at new routes of immunization, their implications and promise. This I think is very exciting. It's getting away from the old technique of intramuscular injection and looking at new ways of actually delivering vaccines, one of which, number 1002, will look at cutaneous vaccination, the rationale and novel methods for delivering antigen into or onto the skin. So this is looking at different ways of being less invasive in delivering vaccines, and will be discussed by Bruce Weniger. On Sunday afternoon is another one called The Human Genome 10 Years Later. What do we know about genetic susceptibility or resistance to life-threatening infections? This is in W185A, and again is another one that follows up what Dr. Goldstein was talking about this morning. And in particular, number 1013, Human Genetics of Bacterial Disease by Ann Poole, should be particularly interesting. Now on Monday, there'll be an update on monoclonal and antibody-based therapies. This is another important arm of trying to address how we can treat infectious diseases without antibiotic or that would augment antibiotic therapy. That session is in W185A, and in particular 1599 looks at monoclonal antibodies for Clostridium difficile infection. And I'm sure many of you are aware that Clostridium difficile, or C. diff, is an emerging organism in the community, and having novel ways of actually treating that, especially antibody-based therapy, is something of intense interest. On Monday as well is a session called Global Threats to Child Health, and it's held in W195A. One of the particular interesting talks in that is on malaria and the promise of malaria vaccines by one of the leaders in this area, Patrick Duffy from NIH. I'd highly recommend that. He does a great job of presenting and will give a great overview. And lastly, on Tuesday in the morning is a session on host response and susceptibility in W196A, and in particular, paper number B1697A looks at some of the challenges of our new vaccines in dealing with the whooping cough or pertussis epidemic, and is entitled Marked Acellular Pertussis Vaccine Failure in 8 to 14-year-olds in a North American Outbreak. And this is particularly relevant when we are trying to think about novel ways of approaching the population, especially older populations with pertussis vaccination, to get at this outbreak.
Great.
That does it for me.
Yep, thanks, great. Okay, so I'm covering all the other things, and I guess starting off this afternoon, in fact, last count there are 5 sessions all running simultaneously, which are potentially of interest. From 4 to 6:30 is Clinical Infectious Disease Breaking News 2011. Now this session not only has a number of papers being presented about endocarditis and other key topics, but the opening session of that is a mini lecture which is summarising the recent ETEC, HUS, in other words E. coli outbreak in Germany and the problems that caused by the head of the European CDC. And then the final 3 papers of that session are actually 3 late breakers specifically on that topic with research, various areas of research on the outbreak. So if you're wanting to cover the recent German outbreak and the impact, of course, across Europe and understand it better, the mini lecture at the start will set the scene, and the last 3 talks, which actually aren't in the main program but they're in the late breaker section at the back, will cover that as well as you'll ever see anywhere. At the same time, and I guess a bit related, is that there's an overview symposium on the role of polymyxin. Many of you know that polymyxin is an old drug that was, as we heard this morning, licensed in the 50s and was pretty much abandoned because of its renal and neurotoxicity. But now we're being forced to use it on many patients because they've got multi-drug resistant E. coli infections and just aware the consequences of the renal failure. And so because it's an old drug, in fact, a lot of the original PK/PD and research that would normally be expected on a drug like this today was never done in those days. And so there's a period of catch-up going on, and almost all of that, the key people in this field for polymyxin are all speaking this afternoon between 4 and 6, session 031 in room W375C about polymyxin. At the same time, 4 to 6, there's a session on Visa and H-Visa. You'll recall this stands for Vancomycin Intermediate Staph Aureus, and there's been some debate. Well, of course, as Staph Aureus has become resistant to multiple different drugs, so-called Visa is emerging vancomycin resistance, and there's been some debate about how important this organism is in terms of clinical treatment failure. The general sense is that it does cause treatment failure in certain key situations, such as when you have prosthetic joint infections or deep-seated abscesses. And that whole perspective, both in terms of the laboratory diagnosis, which is currently flawed with the methods that we use, it's difficult, through to the clinical impact of this organism, will be presented this afternoon in session 035. At the same time, as I mentioned, there's another session entitled Controversies in the Prevention of Surgical Site Infections. This is an important topic. It's session 037, and that's because over the years, it's basically a summary session of the last 10 years of all the various factors which potentially influence your outcome when you're in an intensive care unit. And so there have been various studies looking at whether supplemental oxygen helps or hinders, whether body warming helps or hinders, whether very tight glucose control helps or hinders, and various skin preparations. And so this symposium will put in perspective those 4 key features in terms of your ICU outcome. And related to that, I guess, is a parallel session looking at whether or not screening for some of the multi-resistant organisms, session 038, looking at whether it's worth screening for MRSA and VRE. You know that in past ICAACs we've had debates on the role of screening for MRSA, yes or no, but this session covers much wider than that. It's also looking at vancomycin-resistant enterococcus, screening for fungal infections and so forth. So you'll need to clone yourself into 5 parts this afternoon if you want to get to all these things, but we can perhaps talk about that in the question session. On Sunday, again, a big day. It starts actually, for those of you who are interested in this debate about the chemical Procalcitonin. So there's a Meet the Experts session at 7 a.m. and so Procalcitonin is a bit like the CRP or ESR, where it's a protein that marks inflammation, and there's been a lot of information in Europe about its use in predicting when you can stop antibiotics, for instance, during treatment of pneumonia, and whether it can be used as a marker of bacterial sepsis versus viral infection. And it's been somewhat controversial because the test itself is actually quite expensive and most laboratories don't have it, but in those places that do have it, there have been great claims of its benefit. So the Meet the Expert would be a good opportunity to go and hear the pros and cons of the use of this test, Procalcitonin. I think we've already heard about HIV. The other session that you should think about tomorrow morning, or Sunday morning, yes, at 8:30 to 10:30, session 061, is new diagnostic methods changing clinical care. I'm not sure how much you cover this, but I guess most of you should be realising by now there's a revolution taking place in the laboratory. I mean, a serious revolution, not just for microbiologists who want to do their tests a bit differently, but which makes a difference to clinicians like me in terms of turnaround time. So there are a whole series of new technologies where essentially you can take a culture yesterday, it's grown up on a plate, and straight from the plate you can take a colony off the plate, put it in the machine, and 20 seconds later know what organism it is, thereby saving 48 hours on identification. There are a whole range of new technologies, MALDI-TOF and others, which are going to be discussed tomorrow morning, and these will make a huge clinical difference, save between 1 and 2 days in terms of organism identification. It's currently only available for bacteria, but will soon potentially move into fungi. So that's session 061 tomorrow morning, 8:30 to 10:30. We've heard already this morning about NDMs and the emerging gram-negative resistance, but there's a session tomorrow, session 063, on control of carbapenem resistance in healthcare settings, and that's mainly looking at ESBL spread, but there are some reports also about NDM. That's session 063. You might want to look at that also to add some perspective to this morning's talk. At 8:30 to 10:30, session 066 is One Health and the emergence of antimicrobial resistance associated with the food chain. This is a very important symposium because, as you've already gathered from this morning's opening keynote, we are what we eat. And increasingly it's clear that the emergence of a lot of the resistance in bacteria is related to multi-resistant organisms that we consume in our food, and the reason they're multi-resistant is because those animals were fed antibiotics either to help make them grow faster or because they were farmed in close proximity to each other, so they needed to be given antibiotics to stop them getting sick, so prophylaxis. Now, this session tomorrow is an important one because it starts with a speaker from the World Health Organization where the WHO have defined a list of antibiotics that are crucial for human health and therefore should not be used in animal health unless it's for treating sick animals, of course. And this is the first time this has been done. We're not talking about human drugs as in gentamicin. What they're doing is defining a class of drugs, saying, well, no drugs from that class should be used for prophylaxis or growth promotion. So it's actually defining, putting down a list for the first time to really set the scene for what will come in the next year or two, and that is a pretty detailed discussion with the veterinary industry and the farming industry about whether or not those drugs, which in many cases are used quite widely, should be banned. The second and third speakers are from the US, where there's absolutely overwhelming evidence for both Salmonella and for E. coli, which of course, as we heard this morning, is a common cause of urinary infections, of the linkage of emerging resistance in both those important pathogens to antibiotic use in animal food production. And then the final speaker, Heinrich Wagner, who is head of the Denmark Veterinary Institute, Research Institute. Denmark is a leading example of what you can do in terms of not only controlling antibiotic use, but also measuring what impact that reduction in antibiotic use will have in terms of kilos of meat produced, for instance. And as you'll hear from him, the impact is very, very slight, only a matter of a few percent. So we're dealing with a topic here where in humans we talk about grams or kilograms of drug use. In the veterinary industry we're talking about tons of drugs. It's multiple logs greater, and this is a very important session. We've already heard from Craig about some monoclonal use with C. difficile. Well, there's a session 074, on the molecular epidemiology and clinical impact of C. diff, pretty much setting the scene that Craig has already mentioned about the fact that C. diff is now becoming more and more common in the community and why that is so. Then in late morning, there's an important, I'm not sure if Dr. Bush, Karen Bush mentioned this, but session 082, there's a poster session on ceftaroline, which is about the only new drug to come on board this year, or the last few years. Obviously, there's leading up to this been a lot of developmental work, but this session 082 at 11:15 looks at the PK/PD issues of ceftaroline. Important things because this drug looks like one of the few drugs which may be of benefit, particularly for MRSA and VRE infections. It's the first of the cephalosporins that has activity against VRE, and the PK/PD posters there look very interesting. Tomorrow afternoon, session 121, there are 4 successful stories about carbapenemase producers. Again, this is drawing out this issue of the NDM and multi-drug resistant gram-negatives. But I draw your attention to one of the speakers, Neil Woodford, who is going to talk specifically about NDM. So Neil Woodford is David Livermore's deputy in the UK. He, Tim Walsh and Livermore are the 3 big guns in terms of NDM emergence, and he'll be well worth listening to. And then, of course, tomorrow afternoon at 4:30 is the ICAAC lecture on emerging viral infections. Albert Osterhaus is the ICAAC lecturer. There's just very few in the world bigger than this guy in terms of his expertise in viral infections. He's a veterinarian virologist. And his key discoveries, he's discovered more than 20 new viruses and many, many more hosts. And so this fits into this overall picture that increasingly we're seeing a lot of the new viral diseases are actually coming from the animal kingdom and transfer back and forth, often related to ecological changes and climate change and deforestation and the movement of animals closer to human habitat, or humans moving closer into animal habitats, and then the viruses that you pick up from that. So I really recommend the ICAAC lecture. On Monday, again in the morning at 7, there's an MTE on these multi-drug resistant gram-negatives. And I draw your attention to this because the 2 speakers we've asked to talk on this have personal experience with the problems with gram-negatives. So this is not a theory anymore. Paul Tambaya, who is one of those speakers, works in Singapore, and their discussions now, when someone comes in septic shock in the emergency room, should they start with polymyxin, because the resistance rates are so high in that part of the world. So if you want to get a first-hand experience or hear what it's like to have a first-hand experience, that's a good MTE session to attend. At session 149, there is an update on antimicrobial susceptibility testing. This is the usual session we have, CLSI versus UCAST and so forth. But this year, in addition to the routine bacterial testing, there are topics on CMV, as well as drug testing for tuberculosis and for the new beta-lactam beta-lactams, but particularly CMV and TB are topics that are really emerging fast as big issues. CMV resistance to the new antivirals is a big issue and becoming more and more of a problem with transplantation patients now almost all getting routinely put on CMV prophylaxis, and the emergence of resistance to those oral agents when they occur now means those transplantation patients are developing resistant strains of CMV. So the testing methods in the laboratory to define whether or not it's resistant are actually requiring standardisation, and that's going to be covered in this session. Session 153 at 8:30 on Monday morning is Emerging Issues in Infectious Disease. This is a standard session we have every year, but this year, again, we have 5 really hot topics. The first is that, I don't know if you're aware, but just as there's of the Neisseria, there's Neisseria gonorrhea, and then there's Neisseria meningitidis, that is meningococcus, and just in the past 12 months, for the first time ever, penicillin-resistant strains of meningococcus have now been defined. And so there'll be a speaker discussing the emergence of slippage. Everyone thought that penicillin always worked against meningococcus. It probably still does, but just. And so the emergence of these new pockets of early resistance are a real warning bell. Following on from that, Mike Sheld, who's a professor of medicine in Virginia and a well-known expert in meningitis, will be discussing the topic of steroids or no steroids for patients with meningitis. This is a controversial area that's gone backwards and forwards, but Mike, there's no one better to put that in perspective. And then the last 3 speakers in that session, one is looking at an area perhaps we neglect, and that is emerging resistance in helminths, that is gut worms, which is a huge issue throughout the developing world. Secondly, there is a speaker, as Craig has mentioned, talking about artemisinin resistance in malaria. So artemisinin or artesunate is the new, it's not so new, it's a very old Chinese drug, but it's incredibly active against malaria. Well, sadly now there's emergence of resistance to this drug on the Thai-Burmese border, and you'll hear about that in this session. And then the final speaker is discussing the cholera outbreak in Haiti earlier this year, which many of you will be aware was quite potentially introduced, in fact, by UN peacekeepers, and the impact of that on Haiti and how the control. So a speaker from the CDC will be talking about that. We then run into a new experiment for ICAAC, and that is at 11:15 is ICAAC Live, which is session 161. And this should be a really fun session with Vincent Racaniello, who is going to interview in a sort of talk show type format, interview 3 speakers, Stuart Levy, Arturo Casadevall and David Livermore. If you thought David Livermore was hyperactive up on stage, wait till you see him in ICAAC Live with Vincent questioning him. But we think this will be a really popular session, and also it'll be an opportunity for people in the audience to be able to ask questions and just be a slightly lighter way of gaining a lot of interesting information. I think one other session, perhaps on 2 other sessions on the Monday I should just mention. Session 201, Emerging Issues in Managing Pneumonia. I draw your attention to the mini lecture at the start of that by Didier Raoul. This is at 1:30 on Monday, where he's talking about emerging non-bacterial causes of pneumonia. So in the past we've always assumed pneumonia was largely bacterial and occasionally viral, but as you'll hear from him, it's probably the other way around. And that a lot of our antibiotic use, especially seeing we don't have that many antibiotics left, the means of diagnosing this and understanding better the non-bacterial causes of pneumonia are very important. That afternoon, Monday afternoon, is the ICAAC quiz. If you want to go and test your knowledge against a number of the panellists, some of whom have volunteered and others have been volunteered by us. But it's a fun session, and I've seen the slides, and I can guarantee you won't get more than 2 right. So I think, and then finally, of course, the Cubist lecture on Monday evening that Craig will be introducing. And who better than John Bartlett? I mean, this guy is a legend. There's really not a topic, Craig, I don't think that he's written about or has been decisive about, and he is the Cubist lecturer this year. He has covered everything from anaerobic sepsis right through to new drugs, right through to HIV, through the complications. He's set up a fantastic unit at Hopkins, and he's our Cubist lecturer this year. And then finally on Tuesday morning, there are two sessions which I'd like to draw your attention to. One is session 230, which is about new diagnostic techniques for parasitic infections, fits in somewhat with, I think Craig mentioned, and I'll alert you to that. And the other is session 228. And this is an interesting session. This is simplified testing for reproductive tract infections. So this is home testing for sexually transmitted diseases, home testing for group B strep, and home testing for HIV, and for men who have sex with men, home testing for the special STDs that they often pick up. So this is an emerging era, if you like, a point-of-care tests where you can, a bit like a pregnancy test, instead of buying them off the shelf and as you would now with the pregnancy test and probably going and getting confirmation later, we're now entering an era that for some of these diseases you may be able to do this at home also if that tickles your fancy. So that's the end of my report, and we'd be happy to take any questions.
Yeah.
Okay, my name's Terry Murray. I'm with the Medical Post from Toronto, Canada. I have one question for Dr. Kaiser and one for Dr. Grayson. For Dr. Kaiser, you mentioned the trial that was closed for CMX-001. Can you talk a little bit more about that?
This is a compassionate use. This is not an official trial.
Right.
But it's still interesting to see that even for financial reasons and different other reasons probably, you still have sometimes to close compassionate use trial. This is a real problem even in a rich country where you theoretically could afford the drugs. In this case, for salvage therapy, you don't have access anymore to this drug.
And what country was the program in?
Here in the US.
In the US? Will that be addressed in that talk, do you think?
I don't think so, but you can always ask the question.
Okay. And Dr. Grayson, I noticed there are a lot of late breakers this year. I think over 90. Can you talk at all about, is this, it seems like there are a lot more than there have ever been, and I'm just wondering if there's any reason for that, or if all of this stuff is really...
Well, actually, the number of late breakers, to tell you the truth, were actually the number that was submitted were actually slightly less than previous years, but the quality was so much better that we had to kind of adjust. Normally we're pretty ruthless, but we're always ruthless. But this year we really had to sort of reassess things because the quality of them was so good. So, and particularly I think, you know, if you look at, say, the session I mentioned about the issue about E. coli in Germany, you know, those three talks are incredibly topical, and if you look at the late breakers, many of them are like that. They're specifically on a breaking issue. I mean, they're genuinely breaking, and so that's why we included them. So the fact, Craig, my sense was that they're about the same number, but if you counted them and they're a little bit more, that's fine. But as a proportion of those that were submitted, certainly the proportion was greater this year. We were really pleased with the late breakers, and of course ASM made a big point of, with so many things happening, that we wanted to see this sort of thing, and the scientific community responded.
Yeah, I didn't compare it to last year, but it just seemed like it was going on page after page of late breakers, and I think I counted 91. Don't quote me, as she said. Into a microphone.
Well, I can tell you we were particularly pleased because, you know, there's been a lot of other things happening at this time, and for people to still be thinking of ICAAC and putting in their late breaker, and as I say, we were incredibly impressed, and as we went round on the teleconference at the point that we decided on the late breakers, we had groups who were saying, look, I'm feeling bad because I'm approving so many, but I just can't knock them back, you know, so that was the sense of it.
Yes, hi, Dr. Kaiser. You mentioned that there was a session on XMRV. Do you have the details on when that is and the session number?
No, it was a session we organized because it's a topic that is coming, and you know, you had many papers in very famous journals, including Science, Nature, or I don't remember in details all. And we had a session last year with Controversies, and so we set up a session in a symposium called Evolving Issues or Controversies in Virology. The fact is that during the last 2 or 3 weeks was published a paper that strongly suggests that at least some of the findings might be associated with contamination of some reagents. You know that these retroviruses can be found everywhere. Last year, the speaker showed a very nice slide at the end of the talk showing mice during the night in the lab, and you know that mice can promote contamination with retroviruses. So I do not have the precise answer today because tomorrow we'll get during the session an overview.
What the session number is?
The number of the session is this is the Controversy in Clinical Virology.
Yeah, we did have one question from the internet. They were reviewing the program and noticed quite many presentations on endocarditis, and they were wondering if that is an emerging trend we should be worried about?
No, I don't think it's an emerging trend. I think what's really exciting is for the first time we're starting to get some pathogenesis, as Craig mentioned, some explanation about why is it, for instance, that, you know, as one of the award-winning abstracts is describing why is it that some Staph strains cause endocarditis and others cause overwhelming sepsis. And so we're getting a better understanding about the organisms that cause endocarditis. It's true that there's a session on controversies in endocarditis. I mean, endocarditis is an incredibly important topic, and there's always things happening, and so it's no surprise to have an entire session on endocarditis, because every single clinician in this building would have managed a dozen or 2 dozen cases per year, easily, if not in some cases per week. So it's a very important topic. We would always have a session on it, but for this year, I think particularly pleasing has been the number of new abstracts which are providing some explanation as to why some bugs cause endocarditis, others don't. Some strains within that bug, like Staph, cause endocarditis. That's really the issue. Yeah.
There's also a lot that we've learned about how endocarditis develops, and that's the other session is about, you know, the bacteria-host interaction and what leads to that, as well as better diagnostics and some of the key issues around some of the complications of endocarditis.
This is an important kind of concept because, of course, the way you get endocarditis is you have bloodstream infection and then it lodges on your heart valve. And so whether it's this morning's keynote presentation about all these gram-negatives or other bugs that cause bloodstream infection, one of the risks that, as clinicians, we always worry about is that it'll lodge on your heart valve and cause endocarditis. So, and it's short, unless you pick it up early, it requires a valve replacement, and that's absolutely going to shorten your lifespan.
Are there any more questions from the audience? Okay, then we will wrap this session, and thank you for coming to talk with us. Our next session will be this week in Virology at 2 o'clock Central Time. Our next session will